Now we move towards our next session. So, Dr. Puneet, can you share the slides for next session?
Thank you, Atul sir, for the nice presentation.
So, for next session, our chairperson is Dr. Ravindra, who is additional professor at NDDTC AIIMS New Delhi, and who is also acting as the treasurer for Addiction Psychiatry Society of India, and he is working extensively in the area of addiction psychiatry, and especially in the community-based treatment. And he has several peer-reviewed publications in international and national journals, and he has also received Tilak Venkova Operation of Indian Psychiatric Society in 2017. So I request Dr. Ravindra Rao to take over the further proceedings of the session.
Thank you, Dr. Mukesh. So it's a pleasure to be part of this CME organized by AIIMS Jodhpur Psychiatry Department, led by Dr. Naresh and his team of faculty members and residents. The topic which I've been asked to chair today is buprenorphine depot in treatment of opioid dependence. We know that opioid agonist treatment is supposed to be the most effective of all available treatment modality for opioid dependence treatment. However, even with opioid agonist treatment, we know that there are shortcomings. I mean, it's not as if it is 100% effective. The retention rates, even in the best of the settings, hover around 50 to 60% by the end of 1 year. And concerns definitely remain about diversion of the medications that are used to treat opioid dependence as opioid agonist. In India, we have been using buprenorphine over the last 3 decades or so. And the medications that we use, the formulation that we use is sublingual tablet. Now, globally, world over, people have, researchers have tried to see if we can improve the adherence rate, if we can minimize the diversion by tweaking the formulations of buprenorphine that is available, be it sublingual film or say the long-acting depot formulation. So it will be interesting for us to hear from Dr. Shalini about her experience. What does the evidence say about buprenorphine depot in treatment of opioid dependence? Yeah. So Dr. Shalini is the clinical director for Statewide Center for Addiction and Mental Health, Melbourne, and she's the chair for Faculty of Addiction Psychiatry, the Royal Society of Australia, Chair Training Committee, International Society of Addiction Medicine. Her area of interest is women's health and addictive disorders, treatment of coexisting trauma and substance abuse. And achievements are that she is the emerging leader. She has won the emerging leader fellowship of Australian NH and MRC, and she's investigated on multiple Australian clinical trials. So, Dr. Shalini, please begin your presentation. We'd like to hear from you.
Thank you so much, and thank you everyone for having me along this evening. My evening, your afternoon, I think. I'm just sharing my slides. Just hope everyone can see that. Please let me know if you can't. All good. So thank you for having me along. So I'm going to be sharing this evening on some of our experiences from Australia. And I suppose I'm sharing some oversights of some things that we've found having depot buprenorphine available for probably about 2.5 years now, initially in some clinical trials and subsequently in clinical practice. Sharing this information hopefully gives you a sense of how this might fit into practice in your local settings. But I'm also really happy to kind of share the slides and take information and questions right at the end as well. So just to give you a bit of a snapshot of where I'm coming to you from in Melbourne. Many of you might have been there, possibly pre-pandemic, possibly. We're a treatment centre that has national reach. We provide clinical treatment to people who live in Melbourne, but also we do a lot of telephone and online-based treatment. So we actually treat over 100,000 people a year across the country through our telephone helplines and our face-to-face treatments. Today, I'm talking to you about something that is very much a face-to-face treatment because it's a long-acting injectable treatment that requires people to come to our clinics. In the corner of the photo there, I've just got a photo of where we're based in Melbourne and Richmond. And the suburb of Richmond is very multicultural, very diverse, has a large Vietnamese immigrant population, and also is very close to actually what we would consider the epicenter of opioid use in Melbourne. Quite recently, we had the advent of a Melbourne supervised injecting room built quite close to where our clinic is. And that's the first injecting room in Melbourne. And I'll share a bit more about that. In terms of pharmacotherapy in Australia, just to give you a bit of a sense, and it'll be interesting for you to sort of compare, I suppose, how this compares to your local context. In Australia, these are the most recent statistics we have of our national opioid pharmacotherapy. And in terms of pharmacotherapy, we have a range of different preparations, including methadone, sublingual buprenorphine, and now long-acting injectable buprenorphine. This gives you a sense of the number of clients we have across the country, much smaller country than yours, and also the number of opioid pharmacotherapy prescribers across the country. 1 in 10 of our clients attending pharmacotherapy services identify as being Indigenous. And then in terms of the proportion of people actually coming into treatment and their drugs of concern, increasingly we've seen over time, particularly over the last, that the majority of people coming to treatment are actually prescription opioid dependent rather than heroin opioid dependent. And that's been a trend that we've observed increasingly across Australia, and a trend that's been observed in other countries as well globally. In terms of the age of our clients, we've got an aging cohort of people in pharmacotherapy that's particularly true for people who've been on methadone for decades now. And that means we also see a lot of physical health comorbidities coming along with people having been on opioids for a long time. In terms of supervised dosing, we have a range of different jurisdictional regulations that oversight what people can access. And so here I've shared some guidelines from my state in Victoria. So with methadone or buprenorphine, these are the regulations that stipulate how many takeaways or unsupervised doses people can access. With methadone being considered a higher risk product in comparison to buprenorphine naloxone, people can access a maximum of up to 6 takeaways a week. And so this means that they would attend a pharmacy or a dosing point once a week and then be able to get 6 unsupervised doses. That's the maximum you'd be able to access in methadone. And then with buprenorphine naloxone, if you were considered a low-risk client, you would have access to up to 13 takeaways every fortnight. So you'd go into the pharmacy once a fortnight. The majority of people on pharmacotherapy across most metropolitan cities are probably in that moderate risk to low-risk categories in terms of the number of supervised doses they would have, the number of takeaways they would have. And then in terms of where people are dosing, this varies from jurisdiction, from state to state. But the majority of people in my state in Victoria are going into pharmacies. These pharmacies are just your regular retail pharmacy where people might be coming in to purchase other products. And some of the pharmacies would have methadone and buprenorphine dispensing as part of their dispensary. And so in a state like Victoria, the vast majority of pharmacotherapy is actually operated out of pharmacies. In other states, for instance, if you look at New South Wales and NSW on that slide, you see there's quite a mix. It's also pharmacies, but also you have a range of public clinics and private clinics. In terms of how these dosing points are distributed, you can see across the country there's quite unequal distribution. And for people living outside of the metropolitan region, it can sometimes take hours to actually get to a dosing point, a couple of hours, for instance, for each dose. And that's a significant problem even when you live not so far from the CBD. So you can see the darkest colors are where there's a high density of dosing points. And there's very few across the map. So if you look even in metropolitan Sydney or Melbourne, we still have a range of clients where they're actually coming in for half an hour or an hour to get to a dosing point. And if you see in terms of the types of pharmacotherapy people are having on a snapshot date, this is back in 2020, there's been a change over time of more people accessing buprenorphine. And also over time, there's been a change between the number of people starting to access long-acting injectables. So that context kind of gives you the sense that whilst opioid pharmacotherapy we know is gold standard, as the chairperson's mentioned, we know that there's a really clear evidence for decrease in mortality, including overdose deaths, and a significant decrease in morbidity, including blood-borne virus infections. But we know that for people who want to access pharmacotherapy, there's significant problems with being on pharmacotherapy for long term. It can be a barrier to getting back into life in terms of recovery, re-engaging in work and travel. In Australia, we have the medication itself is free of charge, but we have a out-of-pocket cost associated with accessing treatment in relation to dispensing at pharmacies. So for most people, this is about $35 a week in Australian dollars. And given that many people accessing treatment are actually on welfare benefits, this is a significant proportion of their weekly income. We also know that there's significant geographical problems with access. And we've already heard a lot about discrimination and stigma. Discrimination and stigma are a significant issue when we think about pharmacotherapy as well. Access to pharmacotherapy is an issue, but when you go into a pharmacy to get your dose, you're standing in a line in a retail pharmacy, and you have a constant reminder of the fact that you're someone who uses drugs, constant reminder of someone who's on treatment for that as well. So stigma is a significant issue in this space. And so for us, looking at long-acting injectables, when they first started to come on market here in Australia, there was a lot of excitement because this was considered one of the first innovations in this field for over 15 years and a potential game changer. So I'll start off by telling you a bit about clinical research in this area that we were involved in. The context here is this is from May 2022, sorry. We've just had a changeover in some of the products we've got available. And it gives you a sense of the different types of products. I've only got a snapshot here of one of the products, Buvidal, which is produced by Cameras. And this product is a product that actually has a range of different doses and comes in weekly and monthly injectable formulations. The sister product, which is not on this slide, is produced by Indivior. And that product actually comes in monthly formulations and has essentially a loading dose regimen and then a continuing dose regimen of 2 levels, really. So between the 2 products, people have quite a range of different options in terms of what their doses could be, what their tolerance levels might be, trying to match the actual requirements for the person, and also looking at where people are stepping up or stepping down when they want to come off pharmacotherapy. In terms of this product, I've just got a snapshot from our annual report from 2021, and it really highlighted the fact at the time for us that these medications were being offered more broadly. And for many people, what we were seeing in our clinics was really this positive kind of feedback from clients that they were able to kind of re-engage in work and study, and that stigma was really reduced by being on these medications. And I'll go through and tell you why this was the case. We were involved in this clinical trial that was run across a number of sites across Melbourne and Sydney in Australia. And this was a pharmaceutical sponsored trial, sponsored by the company that produces the Buvidal product, Cameras. And this looked at actually looking at treatment on the buprenorphine product on sublingual formulation versus the subcutaneous injectable formulation. What was good about this trial is we also had a range of outcome measures that were patient-related outcome measures. So also looked at things like quality of life and treatment satisfaction, and compared those 2 across quite a long period of time. Let's see. This is some snapshots of our clinical treatment team, our clinical trial team at Turning Point, including a number of nursing staff that really went above and beyond with this trial, staying late and doing all of the urine drug screens and all of the additional work that was taken. In the corner, I've got the head of our lab, Professor Dan Lubman, who led this trial. And here, what we've got is the outcome. This was published last year in German Network Open and open access, so free for everyone to read. Highly encourage people who are interested to go off and read about this. And so, as I said, this was the first trial that actually compared these 2 products and looked at a whole range of outcome measures that were around satisfaction and function. And what we found is that in this trial, we had 119 people who were randomized, 60 to the depot product and 59 to the sublingual. And those mean satisfaction scores after this long period of time, 24 weeks, was significantly higher for people who got the depot versus the sublingual. There were lots and lots of other secondary outcomes and other things that I don't have time to go through today, but really encourage people to go off and read the study, and happy to take questions by email if you're interested. Attached to the study, we went off and did a second study, which is a qualitative study, to try and really understand what people's experiences were of coming onto the injectable depot. As we all know, with quantitative research, we can put lots of measures in there, but you still only get a little snapshot of what the person's experience is. And this qualitative study gave us a lot of rich information about what people's experiences were. I'll have a snapshot of the article there as well, and some of the themes. Hopefully this, I'm not sure, has come up all that well, but essentially the key themes were really around people's experiences of care on the product, the social effects of being prescribed the product, and improvements for care and patient information as well. So in that clinical interaction with clinicians, understanding a whole range of things about a product that was essentially very new, both to the clinicians as well as to the patients. So I think in terms of experiences of care, there were a lot of themes in qualitative study about the fact that people found it a positive addition to treatment, but also that they highlighted that psychosocial treatments such as counseling was still really important, and that patient commitments were still really important. In terms of social effects, we knew that it reduced stigma being compared to dosing at a pharmacy or clinic, and gave people a lot more time and a sense of more freedom and control over their lives. For instance, they were coming once a month for an injection. The rest of the time when they weren't coming into treatment, they could get on with other things and not think about the fact that they were needing to be on treatment. In terms of improvements for care, this highlighted as well the fact that coming into treatment, this implementation of this new product on the market really needed to come along with a lot of patient information, more detail around coming on to treatment, and then also what would happen if someone was to discontinue treatment or come off treatment. Further themes, which are contained in the paper as well, really highlighted some of these quotes from people in terms of being able to get some information about it, but also wanted to get some information about how this would react if they were going to continue using, what they were going to actually find if they continued using, and also what would happen if they tried to come off treatment, discontinuation or withdrawal. Coming into a context where we've had pharmacotherapy in Australia for since the 1960s, essentially with methadone, so we've got a really good knowledge base, I suppose, both from patients and from clinicians on how to use pharmacotherapy products. So when we have a new medication like this, this really highlighted the need for getting that sort of both patient information from the consumers as well, but also this kind of street information from being able to talk to your friends and other people who've been on the treatment, understand what you're going to expect. But overall, some of these quotes that I've highlighted really showed that people had a chance to get back into the things that they wanted to get back into, and not having to visit a pharmacy every day helped not remind the person of the fact that this was part of their life and helped them move on. We had this quote from an old woman who'd been on pharmacotherapy for quite some time, and she said that one big thing for her, she lived in a metropolitan region, wanted to go to visit her kids, and she really found that visiting her grandkids was a lot easier to do on this medication as opposed to being able to rearrange her life around pharmacotherapy. Now, in terms of some other studies that have come since that original depot study, now we're 2 years down the track. More clinical research in this area has started to focus on that discontinuation process as well, trying to really understand who is this product best for, who is it going to work for and when. And in Australia, we have a really large kind of lived experience and consumer-led movement. And we've had a whole range of different research studies that have spoken to consumers to understand what their experiences have been on this treatment. This study actually comes along with a webinar. So if people are interested, I've put the QR code on there, you can scan that. And you can go off and watch the webinar on our website, which produces the results of the option study, a qualitative study done by the National Drug and Alcohol Research Centre, NDDTC, on focusing on why people who are already on the depot choose to discontinue. And the main points really there are about people wanting to continue using and finding that the blockade was essentially too effective. On the other hand, people saying that it was ineffective for them. For some people, the treatment was different to what they were expecting, particularly people who were coming across from, say, Suboxone. Some people felt they were being pushed into starting the treatment with an injectable product that was going to be around in their system for a month. And so reacting, for instance, to a depot and really kind of understanding that consent process there. And then for some people, they came off the product because they felt that they no longer actually needed treatment altogether, that they'd actually resolved lots of things in their lives. So just telling you a little bit about implementation, and I think this was a really key part of what came after some of these clinical research studies for us in Australia. This is where the rubber really hit the road, I suppose, for us. It's one thing to bring a medication to market, it's quite another to get prescribers familiar with it, patients familiar with it, and really understanding the logistics of being able to deliver a treatment like this. So to start with, as I mentioned, we had a whole range of different consumer bodies work with organizations and also work with the drug companies to develop some consumer guides to starting treatment. These consumer guides are available again on the internet. So if you actually look them up, you'll be able to find some information. And this is quite a comprehensive booklet that kind of takes consumers through that process of what it's like to start this treatment, a diary in terms of what that process can look like day to day, and points people to more sort of evidence-based information as well if they want to read up about it. In terms of the settings and models, so the important thing here is that long-acting treatments, both products, the Buvidal and Sublocade, can't be dispensed to a patient. So as I mentioned before to you, most of the pharmacotherapy models in Australia across the jurisdictions really involve pharmacies being that dosing point. And so here we had an issue in many jurisdictions where we had a product that was being administered by either a nurse or by a doctor. But we had a setting where the dispensation of the medication was a place where there might not be professionals who'd be able to dispense it. So that was a process of about a year of navigating the space, and it was navigating different jurisdictions differently. Currently, there are a whole range of different models that currently exist across Australia. So the first model is specialist addiction treatment model, which is the model that we have in my clinic, where I work, is essentially that the patient might come into the treatment clinic once a month, receive the injection from either a doctor or nurse as their prescriber. We stock the medication on site, and we administer it and account for it on site. The other more common practice models are both in general practice and a combination of general practice and pharmacy models. For instance, for general practitioners to start delivering this required a significant kind of change in practice and a change in their process, because general practitioners had to get safes installed. They had to get Schedule 8 permits, so they had to get time regulations to be able to keep medications like this on site and then administer it on site. For other GPs who weren't able to do that or weren't willing to do that, other models were actually looked at where the medication would be couriered, for instance, to them on a daily basis, or the medications would be taken from the pharmacy down the street by one of their practice nurses or staff and walked up to the clinic for administration. So all of these models are currently in practice, and it's still probably too early for us to evaluate and understand which of these models are working best, both for the clinician and for the patient. But it probably has opened up lots of different options for both clinicians and patients. In terms of harm reduction settings, and I'll show you a picture in a moment of that, in the corner, I've got an image of our supervised injecting room, where people come in to inject their own drugs under supervised and safe environment. And next to that, adjacent to that, through one of the doors, is the consult room. And through the consultation space and the consultation room, you also have a low threshold pharmacotherapy clinic, and low threshold in the sense that if people want to come on to treatment there's a low barrier model where we can provide a range of different medications, including long-acting injectable buprenorphine in that sort of setting as well. In terms of pharmacy-led models and general practitioner-led models, we've now got in some jurisdictions capacity to be able to deliver this injection by pharmacists. So this would be in the pharmacy by a pharmacist. And also, I've got a picture there of one of the GPs to set up a practice model with pharmacy as well. So for instance, where the patient comes to the pharmacy, picks up the medication from one of the practice nurses and gets that walked up to the clinic for administration. Now, I wouldn't be able to give you a presentation at this point without talking about COVID. It's very hard to talk about anything anymore. But I think in terms of COVID-19 and the impact for us in Melbourne, you may or may not know that Melbourne has the ubiquitous record of being the world's most locked down city. Over the course of the pandemic, we had several lockdowns. And I've got some pictures there, which are very unusual if you've ever been to Melbourne, of empty streets and the empty city. So for the timing of this lockdown for us in relation to the buprenorphine product, the products actually came onto the market in late 2019, early 2020, just about the time that we had our first lockdown in Melbourne in sort of February, March 2020. Subsequently, of course, we had further lockdowns over the course of 2020 and 2021. So what we know now is that this whole context, this environment, has actually had lots of impact on how we deliver pharmacotherapies more broadly. We had this joint paper released quite early on in the pandemic. This was a joint publication across our three peak colleges in Australia, the Royal College of Physicians, the Royal College of General Practitioners, and the College of Psychiatrists where I'm from. And this was an interim guidance that we put together that was really promoting the delivery of a range of pharmacotherapies that we see as essential medicines. And so we really wanted to highlight changes in policy and changes in practice that needed to occur for people to continue to access essential medications. This statement is available on the internet and also includes a whole range of different practice changes that happened to be able to allow, for instance, telehealth models of buprenorphine delivery, telehealth models of a whole range of other practice as well. In this document also is further information about the changeover to actually having long-acting injectable medications in that context. Because there's a whole range of reasons why injectable medications are more attractive in a COVID-19 pandemic situation, clearly. One of the highest scale-ups was in our custodial settings. There were a couple of initial research studies that were piloted. You may or may not be familiar with a study called COLLAB, or COLLAB. That was a study of actually using buvidal or buprenorphine in custodial settings. And this scale up, particularly in New South Wales, has happened quite quickly. This transition of people across the long-acting injectable, clearly in an environment where diversion is a concern, this is a much safer medication to actually look at. We published this quite early on in the pandemic again, and this was largely based on a New South Wales data set. And if we can just draw attention to sort of that timeline, that graph, as I mentioned, these products became available first in research trials and then on the market late 2019. And you can see with the pandemic and the lockdowns February, March 2020 and such, you can see that the uptake of this medication, particularly across some health districts, really went up. The important thing here again, in terms of uptake, in many services, there wasn't a significant uptake. And this really leads to kind of understanding what the implementation models look like. Those services that really had a very high uptake were essentially early adopters of treatment. They were clinics, they were the clinicians were already familiar with the product from clinical trial work, from previous work that they've done. So these were clinics where the environment was actually very conducive to being able to upscale quickly because of clinician familiarity and clinician understanding. Now, subsequent to that, that's May 20, that's taken another 2 years now down the track. And it's taken that amount of time for clinicians outside of kind of clinical research settings to become more familiar, more comfortable with these products, to understand which to prescribe for whom, how to help people kind of get on it and come off it. And I think we're still learning as we go. Just a point, because I know the next speaker is going to talk a bit more about telehealth. I guess from our perspective in Australia, telehealth is was certainly embraced during COVID-19. We have a lot of geographical kind of disparities in Australia, and this was really a huge plus for us. This is just a snapshot, though, that one of our registrars published in 2021, looking at our clinic and the modality of attendance, and this is primarily a pharmacotherapy clinic. So you can see that a certain proportion of clients came in face-to-face, and then the orange looks at the video conferencing aspect, and telephone was in grey, and the DNAs that did not attend are in green. And also overlaid on this is the COVID-19 case burden in Victoria. So you can see over time that essentially the level of face-to-face never completely went away, even in the middle of the pandemic. But also what we can see is, if you look at the paper, that the telehealth option was not the solution for everyone. What we really found was that there are a range of clients that are best supported by face-to-face treatment. We found that lots of kind of IT issues, for instance, or digital kind of disadvantages, people not being able to pay for bandwidth, people not being able to pay for credit, really impacts on the most vulnerable patients, the ones who need treatment most. So it kind of highlights what needs to be thought of when we think about telehealth issues as well. And so just bringing that to a close, I just wanted to come back to a point that the previous speaker, Dr. Mbeka, really highlighted is the role of kind of discrimination and stigma in the space, and the need for, when we talk about opioid use disorder treatment, even when we have highly effective medication options, that there is still that gap, that people still struggle to access treatments, people still struggle to come forward and ask for help, even when we know we have something that works. So that really highlights first in a country like Australia, where there's a role of stigma in stopping people actually getting help. And just highlighting against those points that were so eloquently made by the previous speaker, that we really need to treat addiction like any other health disorder. Would we do this for diabetes or for cancer or for any other health disorder? For us, we're running a national campaign to fight stigma and to call for our government to actually invest in fighting stigma. And we're doing this by sharing the real stories of consumers who live with addiction and trying to get a movement behind this to help us change the conversation. So I'll leave you with that. These are some resources that people might want to take snapshots of. Again, I'm happy to share my slides and There's some codes that will link you to the website. There's a whole range of training modules on depot buprenorphine, including webinars and online modules that are open access, free for anyone access. Our clinical guidelines are available. And there's also a webinar done by one of my colleagues that will take you through some of this information in a bit more detail. But thank you very much for listening, and I'll leave it there.
Thank you, Dr. Shalini, for a very wonderful presentation. And the way you said that depot may be one of the important treatment options that will be available for people with opioid dependence and with much greater acceptability. I have my fair bit of questions, but I think let's first hear from the participants as to what they would want to ask you. So one is dose determination and frequency of this buprenorphine depot. So you talked about weekly as well as monthly formulations that are available. So how does one go about using them? And also, how you also said that within these preparations, you also have different dosing that are available. So how does one go about using them?
Yeah, it's a very good question. And I think that very much comes down to the patient sitting in front of me. So what we have is a couple of two different products. And in terms of the products, we've got one product that's only available in a monthly formulation. And we've got another product that's available in a weekly and a monthly formulation. Now, in terms of the choice, there's a number of different reasons that we usually kind of explore with the patient in terms of what they want out of the medication. One of the products is only administrable or being able to be administered in the abdomen. So is a product, the Sublocade product does need to be delivered in the abdomen, whereas the Buvidal product, for instance, can be administered in a number of different sites across the body. So that might be relevant to some of our patients who may not want to, for instance, disrobe when they're actually getting the medication. They might want to have it in their arm, for instance. There might be some site-specific choices in terms of their product. And then in terms of the dosing profiles, for many of us, we have patients coming across from long-term being on Suboxone or sublingual buprenorphine. So then we look at what their tolerance levels are, whether they're still continuing to use on top of that. And then we match that to the dose that comes out of the monthly of the Buvidal or the monthly of the Sublocade. But this very much is sort of both a patient choice and a clinician choice. And some clinicians will favor one product over the other because of familiarity as well. But what we've also found is that the weekly product, it can be really useful for people who are a little bit anxious about coming on medication. They're not sure what to expect, for instance. They're concerned that, what will this feel like if I don't have to take medication every day? Or, will it also hold me? That's something that comes up very often. Is it going to actually hold how much I have, and will I otherwise be withdrawing? So the weekly products give us an opportunity for the person to have a go on it and see how they're going to go. The weekly product is also an option for if someone's on a monthly and they're on a lower dose of the monthly, they're finding it's not holding them, that we can actually give weekly top-up doses on top of that to bring their dose higher until their next monthly injection. So those are just a bit of a snapshot of some of those considerations. But again, those guidelines that I had before on slide go through this in a bit more detail as well.
And how much time does it generally take for people to get adjusted to this long-acting formulation compared to their daily dispensing or sublingual formulation?
Yeah, so in terms of actually hitting that, I didn't have the slides here in terms of the actual dose and how long it takes to reach steady state. But generally for both products in the monthly, it takes about 2 months to get to that point where you're actually on a steady state of that dose. So at that point, once the person has actually reached that point, that tail, if they actually stop taking it, is quite long. So that's also relevant to tell people about when they start the medication, that it is not a product where it starts on day one and wears off after 4 weeks. There's actually quite a lot of leeway at the end of that 4-week period. Most people don't have any withdrawal symptoms for up to 6 weeks on both of those products. On the Sublocade, that can be even longer. So it's important for people to kind of know that. It gives them a bit of flexibility too. They can't always make that appointment 28 days on the dot. But it also means that if they're wanting to come off the medication, that discontinuation process, that process can actually be quite a gradual process of just taking them at one monthly and then just waiting, rather than needing to actually step down, that you have a gradual tail of coming off after a month anyway.
And how much a clinician needs to be trained to adjust doses with regards to long-acting formulation when he's already trained, say, on sublingual formulation of buprenorphine?
Yeah, look, I mean, I think the training process and kind of understanding the familiarization with the products came with a lot of kind of practice, sort of, you know, in the day-to-day clinic settings. But for us, when it first became on the market, there were a lot of online training. At the time, it was in the middle of COVID. And so, in fact, all of the training went online. And so there were a range of sort of webinars and lots of kind of didactic sort of training from that perspective in terms of understanding how to transfer people over, what to look for, what to inform people about. But then the day-to-day practice, I think, is where people kind of developed a bit more of a sense of, you know, with this patient, I think this product might be better, or this weekly or this monthly dose might be better. That came with time, I think. But in terms of, you know, that investment at the start of all of those product information, those modules, the great thing is that that is all now available online and free to access with so many prescribers internationally.
Sir, we are getting a bit late, so we can just take one last question for this session.
Yeah. So, how does this long-acting formulation compare with sublingual in terms of retention rates, dropout rates in that sense?
Yeah, look, I think there's not been a systematic kind of data collection on that yet in Australia. But anecdotally, I know a number of people have presented some data on their own clinics, and the retention rate's fairly high. It's quite high, higher than sublingual formulations at the moment so far. And that's largely because that satisfaction rate is also high. I think people are also, this first tranche of people who've chosen to go on this medication are also largely self-selecting. So they're choosing to discuss this with their practitioners. And only now, probably about 12, 15 months down the track, our prescribers starting to look at how we transition people over who might be coming from methadone to this product and more complicated kind of transfers. That's only happening now. So we'll be waiting to see what that looks like in terms of retention for that group of patients.
Right. Thank you. I mean, we have still some more questions, but because we are running short of time, I am sure we can get in touch with your mails or other social media. Absolutely. And then we can have our questions clarified. Yeah. Absolutely. So thank you, Dr. Shalini, for this presentation, and it has raised more questions in terms of it is very tempting for our patients, not only for patients, but even for us as treatment providers, to give that kind of freedom to the patient to move about, not come to the clinic on a daily basis, or even take away doses on a weekly basis or so. That kind of freedom is something which we would very much want for ourselves and for our patients to be given. So thanks a lot for this enlightening speech. Thank you.